Hey, BC here for BC Nephro. Thanks for watching. I'm Dr. Brian Cronin, board-certified nephrologist and clinical specialist in hypertension. Today's topic, medication treatment for hyperlipidemia and the kidneys. We're not going to get into the indications for treatment of high cholesterol, elevated lipids. Instead, we're going to get into the potential concerns about adverse renal effects, nephrotoxicity from some of the common medications used. We're mainly going to talk about statins and fibrates. But before we get into that, make sure you check out the other videos at this channel. Check out bcnephro.com, where you'll find articles not only on this topic, but on a wide range of nephrology subjects. I'm also on Instagram at bcnephro. Links to all will be in the description below. But now, let's get into it. Many, if not most patients with kidney disease will have indications and will benefit from medical treatment of their hyperlipidemia. The most common medication that's going to be indicated are statins. Now, patients and some clinicians may be concerned about potential nephrotoxic effects of these medications. Let's get into the data. First, concern for a potential cause of acute kidney injury. There have been some studies that have looked at this. The first is a retrospective review of patients in Canada who initiated a high potency statin versus a low potency statin. They looked at these patients and looked at the incidence of acute kidney injury hospitalization within the first 120 days of prescription. This study did find a higher incidence of hospitalization for acute kidney injury in patients prescribed a high potency statin who did not have underlying kidney disease. At baseline, the relative risk was 34%. However, the absolute risk was pretty low. They estimated the number needed to treat for one hospitalization with acute kidney injury was about 1,700. For patients with baseline chronic kidney disease, they did not find any statistically significant increased risk for AKI hospitalization. Subsequent to this, there was a meta-analysis that looked at almost 500,000 patients and concluded that statin use was not associated with any increased risk of serious adverse renal events. So this should make us comfortable in advising our patients that there really is not any significant risk of acute kidney injury from the use of statins. Any risk is negligible. Now, what about rhabdomyolysis? Statins have been known to be associated with this, and rhabdomyolysis is a cause of acute kidney injury. Now, despite muscle symptoms being very common with the use of statins, clinically significant myonecrosis or rhabdomyolysis with the current statins is quite rare. There was a statin, rosuvastatin, which went by the name of Baycol, which had a significantly higher risk of rhabdomyolysis than the other statins. This medication was taken off the market in 2001. Another study looked at the incidence of rhabdomyolysis with some of the statins more commonly used currently, namely pravastatin, simvastatin, and atorvastatin, as well as the fibrates, gemfibrozol, and fenofibrate. Now, this study looked at the incidence of hospitalization for rhabdomyolysis and found that for the three statins I mentioned, the risk of hospitalization was 0.44 per 10,000 patient years. So essentially, they concluded that 27,000 patients would need to be treated for one hospitalization for rhabdomyolysis. Now, when the statin was combined with a fibrate, the risk was somewhat higher. When they looked at patients who were on both a statin and a fibrate with diabetes over the age of 65, they found the incidence to be 5.82 per 10,000 patient years. The number needed to treat for one hospitalization for rhabdomyolysis in this subset was about 480. So again, this is still somewhat rare, but has a high enough incidence that it may be seen more often. Patients with this combination should certainly be counseled to monitor for the symptoms, which would be severe muscle pain or weakness and or a darkening of the urine. Now, moving on to fibrates. In addition to the risk of rhabdomyolysis, both with gemfibrozol and fenofibrate, particularly when you use a combination with statins, there is another condition referred to as Fenofibrate Nephropathy. So fenofibrate has been observed to cause a reversible increase in the serum creatinine. Personally, I see this quite often in patients referred to me with an elevated creatinine. One of the things I look for is if they're on fenofibrate, and if they are on this medication, I see if I can either decrease the dose or discontinue it altogether. When I do this, I often see an improvement in the serum creatinine. There are several proposed mechanisms for why this would be the case. The first proposed mechanism is that fenofibrate may impair the tubular secretion of creatinine. Now, creatinine is a kidney function test because it is mainly excreted by the kidney by glomerular filtration, and therefore it can be used to estimate GFR. A smaller percent is eliminated by tubular secretion. The effect on the serum creatinine becomes higher when the GFR is lower with chronic kidney disease. A medication commonly known to do this is trimethoprim, a component of the antibiotic spectrum, and fenofibrate was proposed to work by the same mechanism. A second proposed mechanism was that fenofibrate somehow increased the creatinine production generation by muscle, and in this case would increase the serum creatinine without lowering the GFR. This phenomenon can be understood by the awareness that people with increased muscle mass will have a higher serum creatinine level at the same GFR, the same kidney function. And this is the reason why the calculations for estimated GFR use things that are proxies of muscle mass, specifically gender and age. I will link another video and article that goes over these aspects of creatinine and GFR in the description below. Now, the third proposed mechanism is hemodynamic, an effect on glomerular pressure, intraglomerular hemodynamics. This postulates that fenofibrate has an effect on vasodilatory prostaglandins, therefore impairing vasodilatation of the afferent arteriole going into the glomerulus. Under this situation, there will be decreased glomerular pressure and therefore decreased glomerular filtration, and the serum creatinine will rise. This effect would be reversible upon discontinuation of the medication. So there was another study that looked at patients on fenofibrate in the Acute trial. The article at BC Nephro will have links to all the studies that I mentioned and a link to the article will also be in the description below. So the Acute study had a subset of patients that were treated with fenofibrate, and the median duration of the study was 5 years. After the study was completed, they analyzed some groups of patients that had been treated with fenofibrate. They observed that a certain percent of the patients treated with fenofibrate had acute rise in creatinine greater than 20%. They took these patients and analyzed what would happen if they discontinued the fenofibrate after they had been treated for several years. There was a control group, which is patients who were treated with fenofibrate who did not have a significant increase in creatinine. They defined this as an increase in creatinine of less than 2%. They observed, even after several years of treatment, when they discontinued the fenofibrate, the creatinine returned to baseline in less than 2 months, about 51 days. Interestingly, the creatinine still remained higher than the patients who were on the fenofibrate and did not have an increase in creatinine at baseline. That subset of patients who were treated with fenofibrate all along actually had a decrease in creatinine over time below their baseline. Now, this study also looked at Cystatin C. Now, Cystatin C is a marker of glomerular filtration and is not affected by tubular secretion and not affected by muscle mass. I'll also link an article and video on Cystatin C in the description. So what this study found is that the change in GFR estimated by Cystatin C correlated with the change observed with creatinine. This would suggest that the mechanism for the fenofibrate increase in creatinine is not impairment of tubular secretion or increased creatinine generation in muscle, but in fact the impaired renal hemodynamics based on an effect on the vasodilatory prostaglandins. So that's it. Thanks for watching. If you made it this far, you might as well hit like and subscribe. Leave a comment or question that you have about treatment of cholesterol in patients with kidney disease or potential nephrotoxic effects. Share this video with someone who you think might want to learn about this topic. It's spreading the message word of mouth that really helps the channel grow. And until next time.